Doctor's decision for tonsillectomy can sometimes feel controversial. I'm Dr. Carmen. I'm an ENT surgeon with 20 years of clinical experience. And in this video, I'm going to give you the framework this decision deserves. So, whatever you choose it clearly and for the right reasons. Let's name what is actually happening when you are trying to make this decision. You've probably had the experience sitting in a consultation room and leaving with less clarity than you arrived with. Not because your doctor didn't explain things in the right way, but because explanation was clinical and your question was human. You weren't asking about criteria and thresholds. You're asking, is it worth it? Will I regret saying yes or will I regret saying no? If you've had two different opinions and you are still carrying that confusion, it's because you are navigating a genuinely complex decision with real stakes, while you are exhausted from another infection and running on your third course of antibiotics. First, a quick word about what tonsils actually are, because it changes the way you are thinking about removing them. Your tonsils are part of a ring of lymphoid tissue localized at the back of the throat, your body's first line of defense against things that you swallow and breathe in. Think of them as bouncers at the door, flagging problems and alerting the rest of the immune system. They do important work, particularly in early childhood, when the immune system is building the library of threats. But those same bouncers can become a problem later on. When tonsils get infected repeatedly, they can become clinically inflamed, harboring bacteria in their crypts, swelling with each new episode, and sometimes obstructing the airway during sleep. At that point, the bouncers aren't protecting anymore. They are causing more problems. Here I want to address something I hear in almost every tonsillectomy consultation. Many patients are asking, but don't I need my tonsils? Aren't they part of my immune system? It's a completely understandable concern. Tonsils are lymphoid tissue and the connection feels obvious. But the reality is that by the time most adults are considering this surgery, the tonsils' immunological contribution is minimal. Your immune system built already its library of antibodies years ago. In adults, removing the tonsils does not meaningfully compromise the immune defense systems. The fear is understandable, but it's not supported by evidence. There are two main patterns that bring people to this decision. The first is the recurrent infection pattern. You get tonsillitis, you are very ill with fever, pain when swallowing, barely able to eat. It clears with antibiotics, but then it comes back 3, 4, 7 times a year. At some point, your doctor starts to suggest that this cycle might not break on its own. The second pattern is the obstruction pattern. This is less about the infection, is more about obstruction, and is the most common reason children have tonsillectomy today. Some of you are watching this episode because of tonsil stones, cryptic tonsils that trap debris and cause discomfort and consistent bad smell. Tonsillectomy can resolve this, even though it's not always the first step. Now, recurrent tonsillitis is not a benign cycle just because it keeps resolving. Each episode carries risks, and the cumulative effects of repeated infections matters more than many people realize. Acute complications can happen during a severe episode. The most common serious complication is peritonsillar abscess, so-called the quinsy. Less commonly, infection can spread beyond the tonsils into the deep spaces of the neck, causing a parapharyngeal or a retropharyngeal abscess. This is rare, but when it's happening, it's a real emergency. Then is the rheumatic fever. When tonsillitis is caused by group A streptococcus, improperly treated or goes undiagnosed, there is a small but real risk of immune system generating a response that attacks the heart, the joints, and the nervous system. In high-income countries, this is uncommon, but is not zero. In children who are having repeated streptococcal infections year after year, it's one of the strongest arguments for tonsillectomy. The decision about tonsillectomy is never just about whether the last episode was bad enough. It's about what the pattern is showing over time. Your doctor may also request an ASO titer, a blood test that measures antibodies to group A streptococcus. The normal values are below 200 in adults, below 150 in children. If it's elevated, it's an objective evidence of the pattern, even when the throat looks clear at your appointment. Now the symptoms that should not wait for a routine appointment are as follows. If one tonsil is significantly larger than the other, particularly if it's appeared recently, feels firm, or it comes with a neck lump, needs an urgent ENT assessment. If you develop a swelling that pushes the tonsil toward the midline, makes it hard to open your mouth fully and gives you a muffled voice, then it might be a peritonsillar abscess, a quinsy, which needs same-day assessment. If you are having difficulty breathing alongside with any throat symptoms, that can be an emergency, so please seek immediate care. I want to tell you about a patient that I saw a few years ago, a woman in her late 30s with 6 episodes of tonsillitis in the last 18 months. She'd been told by her GP that surgery was an option, but nothing stronger than that. When she came to me, she asked almost apologetically, "Is it bad enough yet?" As though she needed to accumulate more suffering before she was entitled to a solution. There is a particular kind of loneliness in that question. The feeling that the room is full of experts and they are having a conversation about your life, but somehow you are waiting outside it. I want to come back to that question because it contains something important. There is a clinical framework that doctors use when assessing recurrent tonsillitis. You might have heard the numbers. 7 episodes in 1 year, or 5 per year for 2 years, or 3 per year for 3 years. These are the Paradise criteria developed in 1980s and still referenced today. Here is what those numbers mean and what they don't. They mean at this frequency of infection, the evidence shows surgery provides a meaningful benefit over watchful waiting. They don't mean below this number, surgery is wrong. They are a threshold for evidence, not a gate that requires a specific ticket. Your quality of life is a clinical variable. The missed work, cancelled plans, number of antibiotic courses in an year, the toll of this is clinical information. The woman who asked, "Is it bad enough yet?" she didn't need a different medical opinion. Actually, she needed her own experience taken seriously as evidence. Now, let's come back to the 2 doctors who told you different things. Your instinct is probably to find the one who's right, to resolve the contradiction, to get the correct answer. But consider this. Both doctors have access to the same facts. They both know the number of episodes you had. They've examined your throat. What is different about the way they are weighting the information? So one weights the risk of surgery more heavily. The other one is concerned more about the cost of continued infections. Both are medically legitimate, but those costs, the missed days at work, the fatigue, the anxiety, the effect on your work, your sleep, your family, you know those better than any of the doctors you've seen. The medical evidence tells you when surgery becomes defensible. It doesn't tell you whether the cost of continuing is acceptable to you. That is not a gap in medicine. That is medicine being honest about what belongs to the patient. The contradictory opinions aren't the obstacle to your decision. They are the invitation to make it. Let me walk you through the treatment ladder in plain language. Step number 1 is treat the acute episode. Antibiotics for confirmed bacterial infections, adequate pain relief, hydration. This is where most patients spend most of their time. And for many people, this is enough. Step number 2 is watch and document. If episodes are infrequent or mild, Watchful waiting is appropriate, but watch actively, not passively. This means keep a record with date, duration, treatment, how much it disrupted your life. That log becomes the clinical conversation at your next appointment. Step number 3 is an ENT assessment. Your ENT doctor is evaluating the frequency, severity, quality of life impact, sleep symptoms, tonsil appearance, and of course your preferences. Clinical guidelines currently support a shared decision-making approach, which is exactly what a good ENT consultation should feel like. Step number 4 is surgery if indicated. Tonsillectomy is performed under general anesthesia. It's a day case or overnight in most patients. The tonsils are removed completely, and I have to tell you the recovery takes longer than most people expect. We'll cover the full recovery picture in the next episode of this series. Before I go further, I want to show you something that I think is genuinely useful. These are the current indications for tonsillectomy as recognized by 3 major clinical guidelines: the United States, UK, and Scotland guidelines. They align on 6 clear indications, and I'll walk you briefly through each of them. The first one is recurrent acute tonsillitis, frequency meeting the Paradise criteria combined with quality of life impact. This is the most common indication in adults. Number 2 is tonsillar enlargement, hypertrophy, contributing to obstructive sleep apnea or significant sleep disruption. This is the most common indication in children. Number 3 is chronic tonsillitis, persistent low-grade symptoms that haven't resolved with adequate medication. Number 4, peritonsillar abscess. A single quinsy is a recognized indication in many guidelines. A second quinsy is a strong indication in all 3 of them. Number 5 is suspected malignancy, asymmetric, rapidly enlarging or firm tonsillar tissue with or without a neck mass. This is the urgent indication. This does not wait for any kind of thresholds. And the 6th one is the recurrent tonsillar stones causing significant symptoms. Not all of these indications carry the same kind of urgency. Suspected malignancy is urgent. The others follow the shared decision-making pathway we have been describing during this video. What this table tells you is that surgical decision has a clear, internationally consistent clinical basis. You are not navigating guesswork. You are navigating a well-mapped territory with a surgeon who should be willing to show you this map. A note on children and sleep. For children with obstructive sleep apnea caused by enlarged tonsils and adenoids, adenotonsillectomy, removing both, is the first-line surgical treatment. The results are often significant: better sleep, better behavior, better concentration. If your child has been snoring heavily and struggling in school, this is a conversation worth having with your pediatrician or pediatric ENT. Before you agree to any surgery, here are some questions to ask your ENT doctor. Number 1. How many episodes should I have before recommending surgery and why? Number 2. What are the risks specific to my age and health? Next, what does recovery realistically looks like? Not the best case, but typically. Number 4. What happens if I choose to wait another year? And number 5. Is there anything particular about my case that makes you lean against or towards surgery? These are not challenging questions. These are questions any good surgeon expects, and they will produce a better consultation for both of you. I mentioned earlier the woman who asked, "Is it bad enough yet?" She hadn't needed a different medical opinion. She needed her own experience taken seriously as clinical evidence. She had her tonsillectomy. Recovery was harder than she expected. 8 months later, she told me it was the easiest decision she's ever made. It just took longer than it should have to feel entitled to it. So, should you have a tonsillectomy? The honest answer is probably only you can decide that. But you should be making that decision with a clear head, not in the middle of another infection, and not because two doctors disagreed and you are still waiting for a tiebreak. What you know now is the clinical thresholds that exist and what they mean and what they don't mean. The complications that make the pattern worth taking seriously. And the decision belongs to you as much as it belongs to your surgeon. The quality of life, it's not a footnote, it's an evidence. Being a patient often means sitting in a room full of people who know things about your body that you don't know, and waiting for one of them to tell you what to do with it. Sometimes the most useful thing medicine can offer is not a verdict, it's a framework. I've put together a consultation checklist covering an episode tracker, a symptom log, and some questions from this video. You can bring it with you to your next ENT appointment. The link is in the description. The companion article about this topic is on ENT for Everyone website. And if you are sitting with this decision right now, tell me in the comments, maybe I can help. How long have you been going back and forth with this decision? Hope this episode helped you understand tonsillectomy. Thank you for watching.